Welcome to Eyes and Tomorrow. My name's John Ferris, ophthalmologist.
And my name's Dermot, Keogh, optometrist.
Dermot, we've been so lucky since starting this podcast to interview so many influential ophthalmologists and optometrists. But really, in the sphere of dry eye disease, optometry is leading the way. The key opinion leaders are in the main optometrists. And we've been fortunate to talk to people like Lyndon Jones, to Sarah Farrant, but today we're joined by two amazing key opinion leaders in this sphere.
We really were. So sit back and enjoy our conversation with Connan and Minakshi Jain.
But before doing so, don't forget to subscribe to Eyes and Tomorrow at eyesandtomorrow@substack.com. Enjoy the podcast.
Well, good afternoon, folks, and thank you very much for joining us. Today we have Connan and Minakshi Jain. This formidable duo run the Dry Eye Centre in London and are themselves key opinion leaders in the world of dry eye.
So thank you so much for giving up your free afternoon away from the practice to join us. Just kicking off, Connan, I was intrigued when we first met about your orthoptic background. Tell us a little bit about your time as an orthoptist and then the move into optometry.
That was the first degree I did. To be honest, when I started, I didn't really know what to do. I just landed into it, but enjoyed it. And I think I did my first role on the South Coast. I just wanted to get a job and get started. A year in, I thought, okay, I want to go back into London. And then a job in Great Ormond Street came by. A maternity cover. Yeah. So I snapped that up quite quickly, and then haven't looked back really. Working in Great Ormond Street with such a kind of multidisciplinary area, just is that kind of place that makes you want to do more. And so I then decided, right, do I do medicine or do I go into optometry? And to be honest, I just saw the junior doctors working so hard. I thought, I don't want to do that. I want to get through and start working in a faster way without having to do all the dog's body work and all that kind of stuff. So I chose optometry.
How has that benefited you as an optometrist now with that background? What sort of advantages does that convey in your practice now?
I think obviously the pediatrics. It makes pediatric care so much easier. Just that broad understanding of how to look after children in eye care from very, very early age and have the confidence to do so. It also adds, I also seem to attract a very niche crowd of patients where they're kind of stuck in between disciplinaries. So they've been to an optom, then there's maybe some double vision, some BV issue going on, and then rather than being sent to a hospital where they see an orthoptist, but then they lack the other bit, I can kind of try to gel it together.
You can do both?
Yes.
Minakshi, you did your PQEs at Moorfields, but take us back a bit further. Do you come from a family of optometrists? What brought you over to optometry?
No, I actually come from a family background in finance. So my father's an accountant and my mum's a tax inspector. So nothing to do with healthcare at all. I did contemplate dentistry at one point, but I figured looking in someone's eyes is nice as looking in someone's mouth. I'd done a bit of charity work with sort of Vision Aid Overseas and another sort of spiritual organisation-based charity that I worked with quite frequently. So I knew that the importance of eye care was always going to be at the forefront of sort of most people's lives. And that sort of propelled me to do optometry. I wasn't a surgeon by nature. The blood and gore of sort of doing ophthalmology, for example, didn't really appeal to me. So I stuck to optometry and landed my pre-reg at Moorfields. So that was a little bit surprising because I'm not like a classic academic person, if you like. I'm quite a sort of all-rounded personality where academia doesn't come naturally to me. So it was more of I'm a practical person. I'm great with people, that kind of personality. So when I got the job at Moorfields, I was quite surprised. And I think they asked me something really unique about, if you were to create a research project, what would you do? And I hadn't prepared for this question and didn't have any budding research ideas. Well, I sort of said something like, "Oh, I wonder if the moon and the tidal wave of the moon sort of shifting affects IOP." That was obviously enough to impress them. And at the time, it was Louise and Louise Dan Ehrlich, and they were like, "Yeah, that was quite a unique answer you gave, and that sort of stood you out." So, yeah, I did my pre-reg with them. I actually worked with Moorfields 22 years after that, so I was quite a dedicated member of the optometry department. But then I also side shifted, and I had an interest in paediatric eye care and got a job at Great Ormond Street, working quite closely with Ken Nishall and Lynn Speedwell. And that's where I met Connan. We were in the place in the room next door in our crazy busy clinics. And that's sort of where we became friends.
Fantastic, that was the link. And I remember when we went out for that lovely meal in London, you were chatting about Ken, working with Ken in the early days at Great Ormond Street, and my having worked at US, I completely concur what you were saying, Connan, about that incredible atmosphere, so many dynamic people, and amazing links with other departments, children with multiple problems, Lynn Speedwell, Lorraine, and the electrophysicist Dorothy Thompson, all that team, great team to work with. But then you took the move, you decided to leave the NHS and go into practice together.
Yeah, and how did Connan persuade you to join him, and what made you take that leap from the safety of the hospital?
Well, I did it in phases. I sort of phased myself in gently, so saw that I could cope with private healthcare. And then there was a need for it. I think there is this grey area, I think, as we all know, between what the NHS is able to provide chronic patients and, this gap where patients need answers, they want more explanation, more chair time. And I think the benefit of all of that came together when Connan approached me, joining him in the Dry Eye Centre.
We were working in Great Ormond Street. We thought, I knew how Minakshi worked, and we I'm working with Ken as well, where it was all very dynamic, and it was all he was very supportive about doing something that you're passionate about.
Yeah.
And so I think with that kind of same energy, we thought we'd carry on with this clinic together.
And that makes sense. You do need that dynamic approach, don't you, when you're running like a dry eye centre and a multidisciplinary centre. You've shifted quite a bit of the business. Was it an organic move to set up the dry eye centre, Connan? How did you get to that percentage you are now? Because both of you are working, 2-3 days a week in it, I think you told us when we met. Yeah. What was the driver to spend so much of your business model on dry eye?
I do split my time between dry eye and Bernard Holland Tam.
Yeah.
And I think clinically I still do more at Bernard Holland Tam with general optometry, contact lenses. But the dry eye space it's more obviously the clinics are quite demanding. Patients are probably the trickiest type of patients that we deal with. But yeah, we've had to spend a lot of time running the business and making it into a separate clinic, and making it known as a separate entity rather than an add-on service to Bernard Holland Tam. They're completely different businesses.
But I think you said initially you guys were struggling at Bernard Holland Tam to give dry eye patients enough time in a consultation, in addition to looking at field and pressures and back of the eyes. So the clinic was set up as a separate entity.
Yeah, I think that's what happens everywhere, really. I think everyone used to really tag on the last 5 minutes or even less of an exam and say, "Oh yeah, by the way, you've got dry eyes. You should do this, and use this."
Yeah.
And it was at that stage we thought, we need to emphasize this. There's surely more that we can do in terms of testing and understanding what's going on. And actually, when you think about it, the main complaint that the patient has when they come to see you is not about their refraction or something else. It's a lot of it is the symptoms from dry eyes, which we somehow seem to be skirting over quite, blasé style. That's why we.
But we were back in 2018.
Yeah,
2018
exactly.
when we first started.
There was just no understanding, right?
Yeah.
Yeah.
We really.
Yeah, we all were.
Yes. Yeah.
So what does the sort of patient journey look like for somebody who contacts the practice, with dry eye symptoms, just that listeners, what's the process from their first contact with the receptionist through to being seen in the clinic and your sort of general workup? How has that evolved now and been refined and streamlined?
Patients are kind of warned about what to expect. Not told too much because we don't want it to be too daunting. So when they turn up, we follow our routine of questionnaire, get an idea of where they're at. A lot of the time is based on a chat because a lot of it is a counselling session, but also understanding and really pinpointing where their symptoms come from.
Yeah.
Most of the diagnosis comes from that, to be honest. And then we run through a whole load of diagnostic tests. So
we pre-warn the patient that the appointment is going to be sort of a good hour and a half, 2 hours. That initial,
potentially, yeah.
That initial consultation to give us time to really delve into their history. So there's a lot, like you said, a lot of the consult is spent chatting to them. But it's I think it's time that most clinicians they've seen previously haven't necessarily spent with them. So I feel like most patients feel that's a big difference when they come to see our clinic. We do emphasise to all our optoms that work with us that look, this patient's seeking help, that they need help. So you need to give them the patience and the empathy to understand their initial drivers and understand their initial causes of why they're seeking help and why they haven't benefited from other treatments for other drops and things before. And then the questionnaire.
Exactly. And then once we've done all the assessments, we then go through everything, or whilst we're going through it. And the key is to getting the patient to understand what's happening. Why are they feeling this symptom, this symptom? So they can manage it. They know what you're doing. They're not going to just say, "Oh, I'll do what you say," but they can actually understand, why am I feeling this way? How manageable is this? And why are you choosing this treatment for us? So a lot of it is patient knowledge goes much further than we can recommend, right? Yeah, patient education.
And I mean, it's showing them.
And do you show them the videos of your video myography and things? Do you show them those images and say, look, there's your dropout. Here's what your tear film looks like. This is what a normal tear film looks like.
Yeah. This is what's coming out of your glands.
Everyone loves the expression video.
Yeah.
So we do all that videoing. Step.
Yeah.
And let's face it, a lot of them have been on YouTube, and they've seen what comes out of glands, and they're curious, right, to know what's coming out of their glands. So it's good for them to see that.
Where am I at? Am I at the toothpaste? Am I nice and oily? What do I look like? So it's nice that they see all that at the first appointment. So we try to, as much as we can, like Connan said, really embed that understanding in them so that they know, this is a chronic condition. They're going to have to manage it. We're there to be the vector and assist them in things, but actually it's a condition that needs home management and understanding first. And then we summarise, we give them a nice report to take home, so they've got their instructions written out. And we may introduce different drops or different sort of medicated drop regimens. And then we sort of create a little bit of we have a chat with them then about, these are the potential options you could do. What would you can do as little or as many of these as you want. Obviously everything is unfortunately on a budget, so it's most people then decide how aggressively they want to treat their dry eye or whether they want to take it slowly, and then accordingly we would book them in to see the relevant optom again sort of in the future.
And how as a percentage do you feel quite a few they'll come to you because they've been elsewhere? I get that. You've then demonstrated them. But obviously it's really important that you then get them back in and take it for treatments and to get to see them. Is there something, is it the diagnostic imaging? Is it showing them the imaging? Is it that brings them on board to say, I'm going to stay with these guys. I'm going to join their treatment protocols. How easy is it for you to kind of bring them from that stage, that very detailed and worthwhile appointment, to treatment? I mean, do you do a treatment on day one, or do you just say, we'll tell you everything, give you the report, and then get you back in? How, because it's a business.
Yeah, it's business as well. I mean, we don't always do treatment on the first go. I think the main priority on that first treatment is to understand or convey what we think is the right diagnosis of what's going on, and then to formulate a treatment plan or options of treatment plans, because some people might be happy with their symptom and they can manage it themselves. So we don't have to treat everything. And obviously we know that it's not possible to treat everything. So it really depends on, it's a mutual kind of discussion about what is the best for that patient. I think we're lucky in a way that we've got a reputation and we don't have to sell. It's not about selling treatment so much. We advise, and we advise what is the best, really. And thankfully, a lot of patients do. I think we convey that we understand what's going on. I think that's key. And they have confidence in what we're advising in terms of treatment.
And we're both dry eye patients ourselves, so actually that really helps relate to our patients. So, same boat as you guys.
Yeah.
We always said home therapies. We do, Connan sleeps with night goggles on, or
I didn't want to tell him, but yeah, I do.
Post the surgery, post surgery patient, all these things that affect our eyes ourselves. So we really do, everyone's, I think, in our clinic that comes to work for us and with us, really understands the chronic nature and the debilitating nature of dry eyes, because they all have dry eyes themselves to some degree, which I think really helps relate to patients. But to answer your question, Dermot, we do try and book the next appointment with as a follow-up at the same time, so that the patient knows they've got a goal to work towards with the initial management we're prescribing, if you like. And then they know they're going to be followed up to check which of those have helped, which things haven't helped, which things they might need a bit longer on. So all of those things are discussed. And like Connan's already said, we don't jump into, you should do IPL straight away or do LLT straight away. It's a case of what's right for each individual patient. So they get an individualized, tailored approach. Every patient gets heated and expressed, which I think is a semi-treatment in itself, really, if you haven't had that done before. So at that initial consultation, that it's a little stepping or a little, springboard, if you like, into what is possible if they did more treatments. So I think that builds their confidence, and our follow-up post initial assessment, if you like, that conversion rate, it's pretty on par and quite nice. We're quite happy that most patients trust us to come back at least one more time. Yeah.
When we visited your amazing clinic, I was intrigued to hear the three of you chatting about expression and the different instruments. And some instruments, you had a couple of favourites, but what have you found in your experience the most durable and most effective expressing forceps, if you were to? Because there was a couple you were saying they tended to break after a while and not so robust. If somebody was starting off in practice,
the gland expressors, well, I think we touched upon one that we used to buy from Mid-Optic, didn't we?
Yeah, that's
that
right.
seemed to be
Original.
the most durable one, and I should mention that they were single use, but clean thoroughly. They hold up. They really still hold up. You could tell on the slit lamp, up close, the surface looks good, but you have to replace them, and but they seem to be the most durable ones. Oh yeah,
so pressing tender lids or
Yeah.
a chalazion, you might change your approach slightly and
Yeah.
be a bit gentler.
Of course.
Yeah. Well, we also talked about that Mastrota powder where we can get further in to squeeze the glazings in.
Yeah. With the pad.
Yeah, exactly.
Eyes on Tomorrow podcast is supported by Topcon Healthcare. The Topcon Terra combines placido-based corneal topography with a comprehensive dry eye suite. The dry eye suite is fully aligned with TFOS, JUICE 3 and features non-invasive tests such as
Tear meniscus height, blink analysis, lipid layer myopography, Lysomen green and fluorescein imaging. And the fluorescein imaging in video is a particular favourite I find.
It uses many of the popular grading scales, all of which are integrated, including the OSDI-6 as recommended by JUICE 3 and also the DEQ-5.
So this finally generates a brilliant structured report. And so for anyone thinking of having a dry eye practice or setting up one, this is an invaluable piece of equipment for your needs. IPL has been part of your practice since you were the first in the UK, weren't you guys, to use IPL?
Yeah.
As we all know, you're using the luminous. I know you've got a couple, if not three there possibly, but you've got a lot, and the low level light. How two questions really. How integral is it? And how has your treatment regime, how you use it, maybe not necessarily the exact protocols, but how has that evolved as the years have gone on?
Yeah, I mean, when we first started, it was a bit of a leap of faith because no one else was doing it. But thankfully, as we've gone on, more studies have come on. We've had, I guess, when we first did it, we looked at the US, so the US was starting to do it, and Australia seemed to be a step ahead of us in most things, even with, dare I say, myopia control. I don't know if I'm right about that, but
Controversial there.
yeah. Well, in terms of like IPL, they had the technology about a year before us, so I was kind of keeping a tab on their progress. But as we went on, we had the confidence to say, actually, this helps. This helps to reduce inflammation. We're seeing gland improvement, and so as we went on, we switched to luminous to upgrade the ability to treat with IPL technology, and so we've just and tailor it more. So it is integral part of dry eye treatment. But hopefully there are newer techniques and newer treatment options on the horizon.
And as you know, Dermot, you can't use IPL on everybody. So it's nice that now we have the ability for red light and blue light therapy, because I think that provides patients that aren't necessarily suitable for whatever reason on IPL, that you can offer something else to heat and provide that in-depth light energy. So I think it's become both. I think we use equally now, if not together sometimes. So I think integral part of the practice for sure.
No, likewise, I agree. I tend to use them together and sometimes as a standalone, and I think they're integral to part of your plan, aren't they? I would agree with that. Yeah.
You mentioned about the importance of the sort of the long-term nature of your relationship with the patients, and making it clear at the outset that it's something that's going to be at least 12 months, and giving them realistic expectations. How does your team sort of work together to keep that sort of messaging consistent, going forward at multiple appointments? How do you keep the patients on board when quite often the progress is steady but slow?
So I think every patient has access to the clinician's email address. So there's questions they want to ask ad hoc in between appointment sessions. They feel like they've got that point of contact. We've got a great receptionist who again directs, and if they WhatsApp questions, she directs them to the appropriate practitioner. So there's always that point of contact, which I think is really important, especially because sometimes at 3 a.m. in the morning you might be thinking, oh, I don't understand what they told me about X, Y, Z. I need to speak to somebody. And we often do get emails at odd hours, but we reply them at the clinical time. But at least they know appropriate clinical time. But at least they know that person they're seeing, the person they've been chatting with all this time, that rapport is built and they're being replied to by that same person, which I think is really important, because how often do you go to the doctor and not see the same person again? It's really inconsistent then with your...
Very frequently.
Yeah. And there's always a lot of us in the clinic, so actually second opinions are always good too. So we're really blessed that way. That, I can just run down or, knock on the door next door and say, oh, I'm seeing this. Do you agree that this is what we should do? Or do you think that we need to order X, Y, Z test? And that's really, really unique.
Yeah, it is.
Yeah.
And also, just going back from about the IPL kind of treatment, I think we've been doing it long enough that we tell patients from the outset that it's not just 4 and you're done. If you're severe, you would need more treatments.
Yeah.
And I think we really, personally, I would like to get that, across more with all the new practitioners as well. I know a lot of studies were based on the 3 treatments and the 4 treatments, but actually in clinical practice, we've seen that you need more to get to that level. Once you get to that level, you can then have the patient space out a little bit more.
Yeah.
So I think it's key that you get to a certain level of control and improvement before you say to the patient, okay, right, now we can lengthen it out with confidence. And our practitioners have taken that on board, and that's how we we know that it's not just for and whatever status you're at, we're going to leave you alone. Patients get lost, they go away saying nothing's helped.
Yeah.
It's like doing a steroid course. If you haven't taken it far enough, that information is just going to come right back.
But I think because the conversation is had at day one, they know what to expect. We're not going to promise you results after X number of treatments. It varies from individual to individual. So, but eventually you'll be in once a year, and that will be your checking point, and you'll feel confident that you can manage yourself between those appointments.
I've just totally agree with you. I've taken the number 4 out of my plans completely now. I just don't talk about the number 4. I just say it's going to take us this time. It could take 6. I think you look like you could even be a lot longer, and it's really nice for you to hear you say that, because sometimes when you're in your own practice among a few of us here, but I totally agree. It could be 5, 6, 7, can't it? And then you feel you're just coming over the hump. And also I think that number 4 I used to find was like a cliff edge.
Right,
okay. It felt like as if I don't know if you guys found that, and they were nearly anxious at number 4, and I thought, we need to get rid of the number 4 out of here, because that just kind of made it more difficult, really.
It definitely has to be a tailored approach.
Connan, you mentioned inflammation. A lot of your patients with ocular surface disease may come to you on a load of different medications, preserved medications. Sometimes it's hard to differentiate whether it's the treatment they've been taking is making their dry eye worse, or whether it's the underlying condition itself. Do you have like a washout period sometimes where you just say, guys, just stop all that?
Well, yeah, I mean, we've all seen that patient with a bag of drops, right? And they get mixed up and they don't know what they're doing. This doesn't work, that doesn't work. But we've seen that, if you don't try a drop for long enough, you just don't know. And if your eye is in that state where everything annoys it, nothing's going to work. So yeah, like you do a lot in glaucoma care, it's just what do you call it, a drop holiday.
Yeah.
Just stop everything,
drop holiday.
Yeah.
Well, I think we should rename it eye bag holiday, because a lot of them come in having fried their eye bags on their eyes. Just
as well. I mean, I think that's key. People are overdoing warm compresses as well, so it's not just the drops. And
the skin deteriorates.
Or the other holiday is tea tree wipe holiday. Sometimes they do too much. A reset and actually just understanding what's going on there. And a lot of the times it's identifying that actually there is inflammation there, and let's do this first. And actually, many times that I see a new patient, I'm not talking about drops really until later stage. This is something that gives you comfort. Use whatever helps you. Okay, whatever you find you can tolerate, but we need to treat. We have to treat the underlying thing first. That might be steroid to bring everything down. We've seen that IPL works in a better way once you've got that kind of initial kind of like raw inflammation down first. I think where you can do IPL from the offset, but you're going to be inflicting more IPL sessions on that patient. Doing it that way.
And your threshold for using limecycline, doxycycline as a way of altering the viscosity of the meibomian secretions?
We're off of that massively now.
I think that connection between the gut microbiome and the eye microbiome has been sort of shown time and time again, more recently in studies. And I think putting someone on a long drawn-out course of either limecycline or doxycycline, I think it's a very primitive approach. And I think look, antibiotics has a definite place in the world, but I think in dry eye chronic management, going on and off these strong antibiotics really do affect the biome, affect the balance. And I think, patients then don't get the necessary effect, or they just drop straight back to where they started as soon as the medication stops. So we try and rein it back in a bit with the antibiotics.
Yeah, I think people tend to be on it long term when it works, and it does work really well, right? You have your person on long-term doxy or limecycline, and it really works for them. But when they stop, it tends to creep back again. So I'm not saying no, and I think there are people who I still prescribe it. There are people who just cannot do IPL for whatever reason, and there is that cost element to it as well. And if it works, yeah, we'll give it. But we caveat that with, look after your gut biome, because loads of research has come out saying that we shouldn't be interfering with your gut, but we still have a lot to learn about that. Yeah.
So with your paediatric hats on, I see a lot of children with quite marked, meibomian gland dysfunction, even little 2-year-olds. You would have seen it in your hospital practice in Great Ormond Street, horrendous recurrent chalazion all the time. And so the erythromycin equivalent works well. But what's your sort of thoughts on, in the future of using IPL and low-level light in kids? Because they've got the same disease. Now, you can't express a child, and they're not going to take it too kindly, to that. But your approach, has that changed in children you might see in practice with chronic meibomian gland inflammation?
I mean, I still remember at Great Ormond Street, they used to have to take them under EUAs and do, anaesthetic, severe cases to give them a good expression. And, it's...
Yeah, and Ken still does that, that's his teaching.
Yeah, exactly, especially in the younger generation, the younger age groups are not going to participate in sitting at a sit lamp or even letting get close to them with any kind of forceps device. We're seeing the younger age come through more and more now, with the use of screens, with the interventions of more and more less and less outdoor playtime. There's a lot of this underlying dry eyes, unfortunately, coming in.
I think that's the key is identifying it super early and actually not just watching it. I think we used to watch that a lot, like contact lens wearers when they've got MGD. You think, they're fine, they're not symptomatic, but we know that the dry eye signs are there, and it only takes for them to have a symptom for it to turn into disease, right? Now that we know that, so why are we waiting for that stage? When, especially in children, we can be telling to parents what to do and reduce screen time and
blink more often.
You can use drops more, warm compress in there. Flaxseed Ken used to tell patients to do, to take all the time. Increase flaxseed in their diet.
But also, I think it's with myopia control methods and things becoming more and more common now. People want ortho-K, they want myopia control, soft contact lenses, but there is definite, I think, increasing place in our clinical practice and building it into routines where we do look at the meibomian glands and image the meibography at baseline so that you can see the impact. Are we creating more problems if we are fitting children with these modes of contact lens wear? There's I think a question mark in everyone's head. What's going to happen to these contact lens wearers when they get older? Are they going to be dry eye patients eventually? So I think all of that has become more and more prominent in everyone's mind in our contact lens fitting practice too. But yeah, I mean, on this expressed, what would you say?
Probably.
It would have been a girl for certainly.
Yes, exactly.
Very compliant.
I was going to say.
Much braver Minakshi than boys. You all know that. Yeah.
Well, actually, during lockdown, I had a very young boy come and see me. He was only sort of 8 or 9 and was having issues, and he was very good, actually, I must say, as standing there and getting expressed and in the gentlest possible manner. But we did he did stand and get expressed. So I think 6 or 7 is probably my youngest.
But also I think we think about expression as using forceps, but we don't have to. We can push a little bit harder until you can that expression out. You are blocking a few glands by doing that. So even that gentle pressure is going to do it. So we don't have to put proxy in them and
traumatize them.
So once you've got that under control, then you want to then start doing your treatment. Now, occluding the punctum really can be quite beneficial. I mean, how useful do you find it, Minakshi, to do that? And obviously there is an array of treatments out there, as we know, the plugs and now the Lacrophil gel by Nordic Pharma, the various ones. Maybe talk us through, where they are in your stage of treatments.
Yeah, I mean, I think it's really important to emphasise you have to turn inflammation down. Putting a plaster on a hot surface is not the answer. You want to let the inflammation settle. But I think using a plug or a mode of a punctal occlusion, if you like, as a temporary, sometimes temporary, sometimes a more longer term therapy, really provides a respite for the ocular surface to just recover and recoup while you're trying to implement other measures. I mean, sometimes it just needs that little bit of extra tear volume retained in the eye to help the eye sort of come back to its normal status. So, yeah, no, I'm quite an advocate of punctal plugs. Before we didn't have Lacrophil, so we were limited somewhat to dissolvable ones or soft plugs, which then provide their own irritations. Sometimes the foreign body sensation, they would just fall out even with the best clinician inserting them. They can sometimes just be rubbed out. So, you know, I think Lacrophil's been a great adjunct in our practice, and you know, I'm an advocate of Lacrophil. I think it's quite, if done properly, I think it can provide necessary relief. And has provided necessary relief for some patients. And no one seems to complain about coming back for another round. So it's not that uncomfortable to apply. You know, I've had every patient I think I've done it for has happily said, yeah, I want it again in 6 months' time. So, or 5.5 months' time, whenever the next time to insert it would be.
Yeah, any tips on actually applying the Lacrophil? Is it a straightforward thing to do if you're used to syringing tear ducts and things?
Yeah, I mean, I think if you can syringe a tear duct, you can apply Lacrophil. It's actually a lot more straightforward than even syringing would be, if you like. But technique's important. Like, I don't know, everyone's got a different technique. You know, our other dry eye colleagues that we know around the country do things differently. Some people use you know, headsets with magnification. I prefer a slit lamp. But it takes practice. As with any skill, I think, you know, the more you do, the more confident you get how to position the patient's head or how to help them align to your slit lamp. And then you form your own little technique. I mean, we both do it quite differently. So it's even within practitioners, I think you can use a slit lamp but still do it differently. Yeah. But I think just the more you practice, the more.
And you're normally finding, what, 6 months worth of relief from the Lacrophil?
I think that's what the literature says. I'm not sure. I think it's probably a bit shy of 6 months. I mean, my experience has been about 5.5 months. They're noticing the use of drops has increased, or they're not feeling as moist in the eyes. So I think I would say, I warn my patient, look, literature says 6 months, but I think it's going to be about 5. I myself, I think, I had it in twice now, so I know that it's around 5.5 months. Yeah.
Did Connan put it in?
Yeah.
Do you do it yourself?
Yeah, she could probably do it herself, actually.
Yeah, no.
This episode has been sponsored by Lacrophil Canalicular Gel by Nordic Pharma.
Lacrophil, a medical device, is a cross-linked hyaluronic acid gel designed to temporarily block tear drainage by occluding the canalicular system. By enhancing tear film preservation, it helps maintain the patient's natural lubricating tears on the ocular surface, offering an individualized approach to dry eye management. The quick in-clinic procedure provides full fill of the canalicular system and delivers long-lasting effects for up to 6 months.
Because the gel fills the canaliculus, Lacrophil adapts to each patient's own anatomy, offering a one-size-fits-all approach. It can provide benefit for a range of patients, chronic dry eye, and in the peri-surgical setting for optimizing the ocular surface in refractive and cataract procedures.
Lacrophil first launched in the US, where it is now being used to treat over 100,000 patients. It became available in the UK in January 2026. So visit lacrophil.co.uk to find out more, to book a training session or request a demonstration.
For the more severe dry eye patients, if you've got the sort of Sjogren's type patients, how has your use of maybe of cyclosporin evolved and some of the newer preparations like the Bevizai? Is that having an impact on your practice, or what other groups of patients are you finding cyclosporin is a necessary adjunct to treatment?
I think anyone with that sustained inflammation really warrants cyclosporin in some form. The Bevizai kind of carrier seems to give a little bit more relief. Well, doesn't sting as much anyway. I think that's the major thing. The sting in the drop really affects the compliance, right? I think we've all seen that. Patients will come back. I think myself, I couldn't, being a typical male patient, I just couldn't tolerate it. It was too stingy, and we've got to think about that. And some new preparations just seem to be more tolerable. And what we've really got key now to know if there's still inflammation is on the biomarkers. I think that's such a handy thing to have. And actually, when offered to patients, they want to know. They like seeing a figure showing that there is inflammation there to warrant more treatment like this.
And as with all of us, we like going for blood tests, knowing our iron level, for example, taking a supplement and then reviewing things. Does it get better? Is my medication or treatment I'm doing helping? So it's been a great breakthrough in what we can offer dry eye patients.
So what biomarkers are you looking at? Is it CRP? Is it cytokine?
So we're using, there's IgE, looking for allergy, which surprisingly has been more effective than I thought. I mean, I used to think if it looks like allergy, it must be allergy, but it's handy to know, because most of the time it is, right? But it's handy to know if it's that kind of type 1 sensitivity or type 4 sensitivity, which helps you differentiate, and also to help you monitor treatment progress as well. You can actually see the figure come down as you treat it, and whether it stays treated. Then we do MMP9, which is, I think, the core one to look for inflammatory markers. And then there is the lymphotoxin A, alpha. That's something that we're still learning about, but it's starting to, we think it indicates a mucin deficiency in goblet cell being affected. What's interesting about that marker is that when it's low, that's what it's indicating. There's a sweet spot in the middle where it's kind of homeostasis of the tear film. If it's above that, then you're looking at more of a systemic cause of the dry eye kind of symptoms and appearance.
Can you tell
Really
Connan's our biomarker guru?
Well, I'm not, but there is a lot to learn about it.
Yeah.
It's really interesting, and I'm pretty sure there'll be more coming out soon.
And a common question actually patients have is, does this relate to my blood test results? Is it the same as doing a blood test sort of serum thing, right?
Yeah. So that, especially with the allergy side of things, is we can have ocular allergies that don't show up anywhere else, and there's this kind of link with dry eye, that you get a dry eye and comorbid allergy disease, where dry eye can cause allergy and allergy can cause dry eye. But I think most of us will, if there are significant signs of allergy, we send to a dermatologist or an allergist, and a lot of times when they do the skin prick test or the blood test, it comes back negative. And so that's where it's really interesting to identify in the tears.
Local marker.
And not assume that you can find out what it is systemically.
Through bloods, yeah.
It'll certainly be interesting to see going forward whether tear film biomarkers give you a window on systemic disease, metabolic, hormonal, endocrine, general inflammatory disease. Ocular or looking into one of the companies looking into this. Do you see that evolving over the next decade into more of a sort of subspecialist area?
Yeah, absolutely. I mean, even with the MMP9, when it first came out, I would say the first biomarker available to us, the biomarker test available to us, was for MMP9. And I remember sitting with a group of optoms, and we all did it on ourselves, and everyone was negative somehow. Even though, I've got dry eye, But the person who was positive was the person who had knee surgery recently. So, but she had no dry eye. So really indicate the levels within our whole body. So there's, like you said, it's there is a lot more
Points to other things.
actually find in the eye, bodily wise.
Going back to our conference at the OSI, there does seem to be, it is taking a while to get one instrument to give us all the biomarkers. Is there a reason why it's taken a while? Is it all cost? Is it the instrumentation still prohibitively expensive?
Yeah, I'm not sure. I think a lot of it is approval, but yeah, I'm not sure why.
Okay.
But when we spoke to Jain Peng, she was sort of suggesting that there was a lot of element of trying to work out the accuracy of the test too, because you don't want, the last thing you want to do is identify, have false positives that are coming out, and then you're treating things and they don't work.
Okay.
So I think there was a lot of robust research they were doing into what each marker meant, what level was mean, how accurate, how much tear sample do you need, right, to get a good accurate result as well. Because when we found in our clinic, it's we're able to now test with a smaller sample size because most of our patients are dry; they don't have tears to test. So you've got to try and work out the balance. How much of a tear sample can you?
Yeah, what's normal? What's the normal range?
Yeah, exactly.
Yeah. But I think the other marker will be coming at some stage. It's just, with any development of any kind of treatment devices, there's a lot to get through.
Eyes on Tomorrow is sponsored by Taya UK. The Blepha range from Taya is specially developed for use on the eyelids and includes Blepha Clean Wipes, Blephazole Lotion and Blepha Gel for eyelid cleansing, as well as the Blepha Eye Bag for eyelid warming. The Blepha Clean Wipes are particularly useful for children being suitable from 3 months of age.
A recent addition, Blephaderm, is a 5-in-1 eyelid contour cream that soothes, hydrates, repairs and protects the delicate skin around the eye, reducing under-eye puffiness. Blephaderm adds lid care to warming and lid hygiene as part of the Blepha range.
One of the things that we mentioned when we went out for the meal was the growing referral base coming from cataract and refractive surgeons to you for dry eye ocular surface assessment prior to refractive and cataract surgery. Tell our listeners a little bit about that, because certainly ophthalmologists and those undertaking that type of surgery are acutely aware of the importance of making sure that people have a healthy ocular surface, otherwise their biometry and Ks are going to be off and they're going to have unhappy patients.
Yeah. So a lot of our team, and I think we've all got hospital backgrounds and we work with various different consultants, so we have lots of connections in the world, if you like, and I think also just through word of mouth of patients. We have a number of patients that were coming to us post all these procedures, and we were we're not upset.
A bit late.
And just a bit like, well, how can we crack this cycle earlier where consultants or other fellow colleagues know that, before you have surgery and before you go for any of these assessments, come have a dry eye assessment first. Because actually, if you're normal, then great, have the surgery, you're going to have a success story. But if you're not and you need a little bit of rehabilitation first, then your results are going to be much better and your patients are going to be happier. And so we connected with a couple of different colleagues. We spread the word a little bit, and that seems to be helping. I think there's still a lot of work to be done in that department. Unfortunately, ophthalmologists are a niche of their own, aren't they, John? But I think
Guilty.
But hopefully the message is getting across, and everyone's appreciating that. Look, the results are much better. Their result accuracy will be much better. And it's better to catch them earlier. Yeah,
it's priming that tear film, making it because we know surgery it causes trauma, and especially with refractive surgery, you are severing nerves, and we know we can't now say, not anymore anyway, that the nerves grow back. We know they don't. So that feedback loop has been reduced, and that eye will produce less tears. So how can we maximise that beforehand?
I think there is an element of chair time, right? I mean, ophthalmologists have less time, if you like, even in private practice. Dry eye does require time. It's time-sensitive sort of chronic condition. So I think it is nice to offer that service to ophthalmologists to say, we can support you, if you like, rather than we're not looking to overtake patients or take over things. We're just supporting their practice, as well as having a symbiotic relationship, if you like.
Yeah, you're right. It feels really nice to be able to say, I'm going to do as much as I can here, and then back to you. And I think
For making a decision.
yeah, exactly. And I think some ophthalmologists are happy to kind of outsource that part, because there is that element of, I don't want to say it, but there is that litigation element to it, right? That if the patient,
I was just going to say that, Connan, just litigation.
yeah, I mean it's rife, unfortunately. You know, it's just the way that this country is also going. You know, it's following America, where people are suing for everything. And I think if a surgeon could prove that, look, I identified or I looked for dryness and I've gone for, you know, I've referred or I've actively treated it myself, that's so important in that kind of litigation process.
Yeah.
And I think a lot of the ones in the past have happened where there's been no mention of any dryness at all or any MGD before surgery. So I think that's a really interesting area that we're starting to see a lot of now.
So based in London, it's competitive down there, isn't it? There's a lot of you providing, I mean, probably nobody to your level of a dry eye centre, but you know, you still need to keep people coming through the door. You still need to get footfall in. What are your kind of strategies for marketing, social media? How beneficial is social media and marketing? Or is it just good old-fashioned word of mouth, as Arthur Cummins reminds us when we were at his practice in Dublin?
Yeah.
Well, word of mouth is key.
Anybody? Yeah.
I think we've gone this far mostly with word of mouth. Our
Patients are advocates.
yeah, patients have really you know, sold us, you know, to their friends and family, anyone they hear of who have dry eyes, to say, do you know there's such a thing as the dry eye clinic, a dry eye centre?
Yeah.
But no, more recently, you know, we have, I say recently, in the last year or two, maybe, that we've looked at more of the market, just as we've grown, really, getting more, you know, we've got new staff in, really good staff, we want to make sure they're busy. So, yeah, in the last 2 years, we've kind of engaged more social media. I think Instagram is you, and or we get someone to help us with that. I guess it's important. So I've been told. So we've been told, right?
I mean,
Everyone
we're
keeps saying,
80.
By the people you're paying to do it.
Is that what Minakshi's told you, Conan?
it's so difficult, right? I mean, it takes me about a day or maybe day and a half, maybe longer actually, to do a post. to think of something big.
I thought you were going to say to get ready.
We're ready to do a post, yeah.
No, I think content's important. I think getting the right message to patients and getting the message out is important. You know, we're not camera savvy people. We're not, you know, we're quite camera shy actually. So we're not the best at doing reels and doing all these fancy things that the younger generation can do. But I think having a presence online is important. Do we get a lot of footfall that way? I'm not sure. I think a lot of them come through our website. They come through word of mouth. And also, I guess, just like we said, from referring clinicians. So we seem to be having a steady flow of patients coming through that way. Google reviews help. So, you know, we try and encourage our patients to, if they've got something nice to say, you know, please don't feel like you have to, but please do. You know, it'd be nice to always, you know, a compliment is always well received. So we are trying in different avenues, I guess. But luckily, touch wood, I guess we haven't had too much of an issue in terms of competitors. And like you said, we're in that sort of prime location where there are you know, clinics to go to. So, you know, most of our patients that come to us seem to say, you know, we've done our homework or we've done our due diligence, we've looked around, maybe even been to see other people, but, you know, we like the sound of what you guys provide and how you initially, you know, engage with us and all that kind of thing. So then they come through.
I think you've said it before as well. Just plenty of people with dry eyes, so it's not really competition.
No.
You know, there's probably not enough of us to provide care for these patients. So there are lots of us in London, but lots of dry eye in London as well. Yeah.
And the nice thing is actually we do speak to other practitioners in our vicinity, so we try and keep keep everyone sort of, on par. And, we also do refer to each other. Like, some people, because of location, may prefer to see someone in the Midlands or up north. And so we do try and work together with other practitioners now that we know more of people.
I mean, it's quite clear from when we met you and look, chatting today, you've got a great kind of partnership that works very well. How do you kind of divvy out the work? How do you kind of say, you do this, you do that? Is that just happened organically, that you just, you do everything Minakshi and just Connan just sits back, or?
He was never
Here that way?
No, definitely not. I think we both got different personality traits that work in favour of any kind of practice. I'm quite a people person. I like talking to the staff, finding out what they're struggling with, helping, encouraging.
I do talk to my staff as well.
I mean, when he asks. We're both approachable.
Good morning, good evening.
Without hiding. No. Yeah, we're both quite great characters, but I think when it comes to innovation of the business and bringing on new ideas and developments and technology.
So I want to buy stuff all the time,
and I'm always like, we haven't got enough.
Yeah.
You're the flight.
Yeah, exactly.
You're the credit controller now. No, you can't have that, you toy Conan.
Shiny objects.
Well, it's so just tempting, isn't it, to try and provide everything? And I think
boys and their toys.
Yeah, well, there is that. And
what do they say? Shiny object syndrome, right?
Shiny objects. Yeah,
new things.
Yeah, I do get attracted.
So with any sort of relationship, a marriage or a partnership, there's always just the odd irritating habit the other person has. So we're going to ask you, Minakshi, if there's one thing you think, Conan, and we'll ask the same question of you, Conan. Any little quirk, any little endearing trait that you think, just take a deep breath.
Yeah.
She's just trying to choose one out of the many. That's the problem right now.
Well, you don't have to limit it to one.
You've got to put me on the spot now. No, I mean, without sounding like Colin's perfect, I mean, he's very good at sort of encouraging team, encouraging me, and also just being that sort of presence, if you like, without saying too much. So, sometimes I'm like, say some more. Like, give me a response. I'm asking you about a problem or a conviction we've had, or whatever, and he'll just be like, it's fine. Just let it settle. And I'm like, no, I need more response than that. So that's probably my biggest bugbear. He's too quiet sometimes.
Don't know what you're talking about. I was just dreading what she was going to say. Really, I think
you got off lightly.
Yeah, I think I got off lightly. I think with Minakshi is that she's so opposite to how quickly she does things. So I have to mull on something for quite a while. So even if I've got a brand new idea, I want to action quickly. By quickly, I mean I'm going to think about it for a couple of weeks, but Minakshi will be like, done. Hold on. So it's not a bad thing, but that's the only thing I would say. In reality,
a woman of action.
Yeah, exactly. But in reality, we've always been like this. We've always been like brother and sister. Everyone will tell you we bicker so much. We try and hide it, but it just shows.
It's like when you guys are aligned, everything worked perfectly in unison. But the minute you guys start bickering, we know that there's going to be after effects, and the earthquake's going to be simmering away. But no, I think it's I think a lot of the optoms refer to us as mum and dad, which is really cringing. We're not that old.
No, but it's
You're not. That's true.
No, my gosh, making me feel old.
Yeah.
So you brought us out to a lovely restaurant in London, that Lebanese, and you guys in London have got a great selection of restaurants. This, again, a question to you both. What would be your favourite kind of restaurant food? We'll start with you, Connan. Restaurant food that you choose to go to, if you could.
I would love to be able to go more to Japanese sushi food, just for the cleanliness, not cleanliness, but the cleanness of the food, and just lightness.
Yeah.
Light and, not have to worry about putting on too much of this and,
Yeah.
Yeah, that's probably my go-to if I could choose.
I like anything with flavour. So bold flavours, flavoursome, Persian food, Indian food. Like one of my favourite restaurants we went to, Honey and Smokes. That's a great Lebanese spot that has lots of flavour and everything. So anything that takes effort to put that flavour in, I think, is always worth consuming.
I got told off, actually, because when I came home, Alison I found the receipt. And she goes, "That's one of my favourite restaurants. I'd love to go there." "Oh, you didn't tell me you went there." I said, "I didn't know it was one of your favourite restaurants in London." So now I'll have to, the next time we're up in London, I can see myself making a reservation. One of the questions we asked Uday Devgan last month, he said there's one conference he's not going to miss, and it's the ESCRS. They're a conference every year you look forward to, so I'm not going to miss that. I'm going to stick that in the diary. That you get the most from?
I think it's the OSI, just because it's so relevant to what we do, and it's also been nice for us to be able to part with our knowledge there as well. But what I love is what I'm looking at right now. It's just the great marriage of optom and ophthalmologists working together, just to be better in the field. Yeah. And I don't think you really see that in anything else, in any other conference. See parts of it.
I think you're right.
OSI is a great mix of the two fields together. Yeah. With one common.
Yeah, I totally agree with that. Yeah. No, and I would echo that completely, Connan. When I went there first, that's the first thing that struck me.
And very much on a par. When you go to ESCRS, there's a lot of optometrists there, and they're playing an increasingly important role. Yeah. But certainly a decade ago, that wasn't really very obvious. It's becoming much more of a partnership and an equal partnership now. And in the ocular surface, optometrists are just light years ahead of most ophthalmologists when it comes to that. You're really sort of leading the way on that front.
And finally, you guys are in a great city, London. So I want you to tell me, what would be your weekend city away anywhere in the world without the kids? What's your favourite city you want to go to?
If you could be teleported there, don't worry about the transport.
No money, costs, whatever. Where do you want to be for 3 days?
For 3 days, I would love to go back, probably to San Sebastian, just to stand in the alleyway, having a good drink and some good food.
So I love Italy, so I'm happy to pick a city in Italy and just mose around the streets and, nice food, walking around cobblestone alleyways and things, but also having the coast. So I would probably say somewhere along the Amalfi Coast is probably one of my favourite picks.
Sorrento, hard to beat, really. Lovely. Thank you so much for your time this afternoon and for your hospitality in London, and thank you for giving us a real tour de force of the dry eye practice, what's current, what we have to look forward to in this exciting field. We're going to have to really up our game regarding the podcast background, because your living room actually is just knocking it out of the park.
We're off to buy a sofa tomorrow.
Thanks again.
Great. I'll be chatting with you both.
Thank you.
So we hope you've enjoyed our conversation with Minakshi Jain and Connan Tan. Please subscribe to Eyes and Tomorrow at eyesandtomorrow@substack.com, and by doing so you'll have access to every bonus video episode. And this month's bonus video is Minakshi and Connan talking about their tips for setting up a dry eye practice. Starting small, growing the practice, the pitfalls to avoid, and their words of wisdom for people who've actually done it. So a perfect listen for anybody interested in developing a dry eye practice.
And you'll also have access, of course, to our monthly newsletter with carefully curated papers specific to this podcast, not to mention the back catalogue, which is brilliant for your self-directed CPD.
For your CPD. So we'd like to finish off by, as always, thanking supporters of our podcast, Topcon Healthcare and Taya UK.
And a specific thank you to Nordic Pharma, who supported specifically this podcast.
So until our August episode, which is going to be a bonus amalgamation, potpourri of all the fantastic best bits from our recent podcast. So perfect poolside listening. So have a great summer and enjoy the August podcast when it goes live. It's goodbye from me.
And it's goodbye from me.